Hello, and welcome to North Country Matters. My name is Bess Kirnie, and I'm a member of the St. Lawrence chapter of the American Association of University Women, one of the civic partners for this show. Today, we're hosting a conversation with Diane Pickering, Director of AIM, Advanced Illness Management, here at Hospice and Palliative Care of St. Lawrence Valley, and Kelly Hitchman, Director of Development and Community Relations, also at Hospice. Welcome, both of you.
Thank you.
Diane, you are a registered nurse and also Director of Advanced Illness Management, AIM, at Hospice. Kelly, thank you for being here.
Thank you for having
me. You support the objectives of AIM through community outreach.
Yeah, absolutely.
And
It's very important that people have access to the information and know about the program that's here to support them as they encounter a serious and chronic illness.
Excellent. Yeah. Now, most people, maybe like me, don't really understand the difference between hospice and palliative care.
Mm-hmm.
I somehow knew they went hand in hand, but how is palliative care different?
Well, about 5 years ago, Hospice made a decision that they wanted to develop a program that would offer services to support patients that were not hospice appropriate. So patients on AIM are not patients who have a prognosis of 6 months or less, as is required by hospice.
Okay.
Our patients are patients with chronic illnesses, and we hope to help them manage their symptoms and educate them about their disease and the process of the disease and how it will progress and things that will happen with them and how they can best deal with it. Our goal, basically, and another thing I should say is we are also not a home care agency, because that is sometimes confused also, that people call looking for help in the home. And we are not that kind of help. We are help in the home, but we are not the physical home care agency that comes in with a bunch of staff that comes in multiple times a week to provide the hands-on care. We are more appropriately or more similar to the old-fashioned house call. So Hospice decided to do this, as I said, 5 years ago. And the original thought was to provide these services, and patients would come here to the office to get these services and the support that we would offer. Well, we quickly found out that wasn't where the need was in St. Lawrence County, that most of the patients who have these chronic illnesses are people who can't get out of their homes. So we shifted gears somewhat and made this, or developed it further, I should say, into a home-based program. So basically, we provide the old-fashioned house calls to patients in their homes who have chronic diseases.
Oh, thank you. So with the understanding that no two of your patients are necessarily alike, can you tell us what are some of the characteristics of the people you serve, and how do you use those characteristics to determine that palliative care, that AIM, is appropriate for someone?
Well, our nurse practitioner is certified in hospice and palliative care and is trained to deal with pain and symptom management, as well as in-depth communications with treatment options and establishing patient goals. These are their goals, not anybody else's. So she's trained in this. The chronic diseases vary. There's a huge variety. I mean, you can see people from the cancer patients who are still seeking treatment, the people who have lung diseases, the COPD, respiratory failure, kidney disease, Alzheimer's, dementia, pretty much anything that's a long-term illness that people have developed, and we can see them at any point in that disease process. We like to get them earlier so that we can be that support for them. Unfortunately, we don't always. Sometimes we get them because people are at their wits' end, and so they're they're looking for any possibility. But we would like to get them earlier. We get these patients through referrals for the most part, and a lot of them come from hospitals, people who have been hospitalized for their disease and are looking to get some support. So the hospitals send referrals over and give us information on the patients. We get them from home care agencies that are in the home. Typically those home care agencies are in there short-lived, and they know that these people need support beyond the length of time that they will be in, so they will refer to us to be sure these patients have ongoing support. The case managers at the hospital, pretty much, and we take self-referrals too. Family have called to say, is this possible? Is there any way you can help me? This is the situation. And if we can, we will. Again, if the patient has a chronic disease and we can get into the home and provide the quality care that we want to provide to them, then we set everything up. We do not become their primary caregiver, and that's an important differentiation also. We are an extra layer of support, again, doing those old-fashioned house calls, but we do not take over the total care of those patients. For one thing, the patients don't want to give up their doctors, and there is no reason to. If they can get to them and they need to get those treatments done, that's fine. If they can't and we can help supplement that care, that's what we want to do. So people have their primary care, but one of the big things that, and one of our goals, is that we also coordinate that care, that we communicate with all of the providers involved in someone's care so that everybody's on the same page. A lot of times you'll have a patient who will go to their cardiologist, to their family practice doc, maybe to a lung physician, and everybody has their own treatments, but nobody ever really communicates everything that's going on for that same patient. Well, we try and pull that all together. So when we go into the homes and our nurse practitioners get the history and speak to patients and determine what their goals are and work with them, then we disseminate all that information. So all that goes into a note, and all of those notes go to every provider that we can identify that's been involved in that patient care. At times we've been called by some of the providers to say, well, we're not seeing them anymore, so please stop sending me notes. But, I mean, that's our attempt, is to make sure that everybody knows what we're seeing and that this is the best way for this patient. Many patients going to a doctor's office won't say what's going on in their homes and how they're feeling all the rest of the time.
Tell me about, I understand the element of coordinating with healthcare providers. On the actual living situation in the home, what do you do there?
In the home, we want to empower those patients to establish what their goals are. We want to educate them about what their treatment options are, and we want to support them. So we want them to have relief of symptoms, even if it's something which, for many of us who don't experience it, don't always understand. People, for example, with shortness of breath, who suddenly get so short of breath, they're terrified in their home. There's nobody there. It's not like being in an emergency room or a hospital. They're terrified. We want to alleviate that, or at least control it for them, so that they know how to respond when those things happen to them. That they know what they can do, that they have the tools, and that they feel empowered to do that.
And what about, you're talking about people who will live alone with a long-term illness?
Mm-hmm.
Oh, and then how do you involve the family with that if they're on their own?
We always try and do a visit with a family member there so that everybody is on, again, the same page. So we like to involve the family, and many times the families haven't had the discussions with their loved ones about where this disease is going or what's happening. So when we involve the family, frequently our nurse practitioners will hear, oh, we didn't know that. Oh, that's great to know. Or, we didn't realize we could do this. And so, again, it's pulling it all together. It's finding out where that patient is, what their goal is, and then to set that plan in action. and share that with other people who are providing care for them. So the families are very much involved in it. And the families often will call us too. So if mom or dad or lives alone and they only go and see them every once in a while, they'll report back to us to say, gee, I went in and this is what I see and how can we help? Or they're calling me for this, that, or the other thing. And we try and work with them as well. So that, again, the whole unit, that whole family unit, is much better equipped to deal with that disease and that progression of that disease.
I think oftentimes what you find in a family is that a chronic disease or an issue, a serious health issue like that, is an elephant in the room. Families have a very difficult time discussing what's going to happen, but it's a reality. A chronic illness doesn't go away. It's something that you deal with for the rest of your life. So it's important to have those conversations, and I think a lot of times it takes a facilitator, and AIM is that facilitator. Family docs and general practitioners, because of regulations and certain things, they don't have the time to sit with a family and a patient and really listen to their concerns and give them viable solutions. And I think that's the difference that AIM makes as that extra layer of support. It's really, like you said, a facilitator pulling everything together. But these conversations are difficult, and I think it's very rare that you find a family that is able to speak openly about a disease and what's going to happen and face it head on.
It's rare.
Yeah, I would say. I mean, in as an outsider's opinion, Diane may think differently, but
And many times they just don't know what the progression is. They may know what the disease is, but they don't know what the progression is. So they don't know that a lung problem will necessarily affect the heart or slow this person down for all of the physical reasons, and the disease process is what's causing all of this. So our goal really is to relieve both the physical and the emotional symptoms, to strengthen the patient, family, and provider communication so that everybody is involved and knows what the decisions are, and then to ensure that that care that's being offered by so many is coordinated. So those are our goals in taking care of those patients, and that's what makes us that extra layer.
And you're supporting the physical and emotional well-being of the patient by educating the family and those around them. But are there not people with chronic illnesses who are basically alone? Maybe the kids moved out to California or whatever, and I'm just thinking that I actually know some people who are lucky enough to have family living nearby, but what if you didn't? Can AIM help?
Yes, we do. We still go in and we have the same discussions with the patient. Sometimes we even put families on conference call. So during a visit, our nurse practitioner will open her phone and talk to the family at the same time that the visit is going on, and they get to ask questions right there. But for those people, and again, not everybody has family, not everybody has that kind of support, and there are a lot of people who are alone, and we do go in and we help them, but we also have other resources that we can use. So the team is basically myself as an RN, a full-time nurse practitioner, and then a half-time nurse practitioner, which we recently added because of our size and demand for our services. But we do have access to resources, so we can use support staff who can, let's just say somebody's living alone and they're having a very hard time paying for their heat while we're in there. We may make some referrals or make some phone calls on their behalf to try and facilitate that. We have, patients who have said, I can't do this anymore. I'm going to need to go to a nursing home. I've realized that I don't want to do it, but as my disease progresses, that's where I know I'm going to have to go because I will not be safe in my home. So we start that process with them, and we help them with their applications and getting whatever paperwork they need. So we have resource staff that we can utilize to help with those types of things as well.
You have a staff of 2.5 people. I know you're smiling. How big is your caseload?
Well, since we started the program in 2014, where we had roughly 30 patients, we're now serving on average 100 patients, and we provide monthly visits to these patients. We will, in addition to those monthly visits, let's just say somebody, as we say, gets in trouble, so their symptoms are out of control. And again, we want to keep them in their homes, we want to keep them out of the emergency room. We will make that extra visit. And I have the daunting task sometimes of rerouting our nurse practitioners across the county, because we're covering all of St. Lawrence County, and they're driving to homes. So you can imagine where some of these homes may be, because we're going from Star Lake all the way up to Messina, and everywhere in between. So if somebody calls and they're having a problem, and myself as a nurse doing the assessment and decide between myself and the nurse practitioner that somebody really needs our help, then we reroute everything. And that sometimes is pretty chaotic, but
Managed.
it is managed.
Okay.
It's managed chaos, and we do it, and we do it without a blink of an eye now. But we have tripled in size.
Since
Since its inception, which the first patient was seen in February of 2014. So we've built it over that time. And it has grown into a 99% home-based. We can see patients in hospitals. The nurse practitioners have the ability to go into the hospital if our patients are in there. They can see them in the cancer centers. They can see them most places. The only place that we do not take patients right now are in the nursing homes. We cannot go and provide services in those arenas.
Okay. Yeah. Oh, my word. A huge area. Small but mighty staff. And this is, well, you said how much your caseload has grown. This is in the face of what has been called the silver tsunami. I'm sure you've heard of that. That we can only expect that the demands are going to grow. I imagine this is going to be a challenge.
It is, and since our program, we have reviewed the results that we have seen, and our patients who are well documenting that they have made less visits to the emergency room, less hospital visits, feel more comfortable with the goals that they've established and the level of support that they get and the symptoms being managed. Our problem is that our services are reimbursed similar to a doctor's office visit. So we get paid through Part B Medicare, and we receive a single fee for that visit. Those visits are also subject to the same deductibles and co-pays that a patient would pay in an office visit. The problem is with the services that we provide, the only thing that's covered is that nurse practitioner going and making that visit. Frequently those visits are an hour or more in the home. So from a time perspective, you're certainly not going to get reimbursed from an insurance company, but 30% of what we do for these patients are not reimbursed by anyone. So we'll get that flat fee for that one visit, but everything else that we do is basically not reimbursed. So as the demand increases and we want to increase these services, we are going to need to rely on other support, be it from hospitals or other agencies, insurance companies, to recognize what palliative care provides and aim providing that palliative care, what it provides, what the incentives need to be, and how they're going to look at redesigning the reimbursement for these kinds of services.
So something will have to change.
Something will change.
Yeah, yeah. And one of your aims is to keep people out of the hospital and keep that COPD patient from panicking and rushing to the ER when maybe they can manage at home. So how do you get the word out about what you're doing?
I think the program really sells itself. I mean, as I said earlier, a chronic illness is not something that you get rid of. It happens regardless, whether it's genetics or lifestyle choices or anything like that. You're kind of stuck with it. And fortunately, when we did expand the program 4-5 years ago, it allowed hospice to begin to see people earlier. So I think that's one of the things that I go and talk about is the fact that under the umbrella of hospice and palliative care, we've established a continuum of care. So as Diane said, once the diagnosis is made, we can begin to start working with these patients. They're not alone until they're hospice appropriate. It's not, okay, you have COPD, good luck. It's, okay, we're here, we're going to link you with other resources. And we're going to work with you, whether it's, a couple of years or if it's a couple of months until you are hospice appropriate. And then we can then work with the family in the aftermath. So we're an organization that's very much patient and family centered. And I think that's a big selling point of it. Anyone with a chronic illness, we're going to try our best to serve. And I think it's very noble that we have 2.5 people on that staff, and they're seeing more than 100 patients on a regular basis, and they genuinely care. And I think the program really does sell itself. Fortunately, we have great backing from physicians and area hospitals, and they're really making the decision to refer to AIM. To ensure that their patients do have all the support that that they need and that they're entitled to through insurance and things like that. So we go everywhere from senior citizens groups to educating physicians on what we can provide, just to ensure that people in our community are getting the care that they need.
So if somebody who's viewing this program realizes that they or someone they love could really use your services, how would they find out more?
Our website was recently redesigned, and it has a wealth of information on what the specific programs are, but the best source of information is picking up the phone and calling our office. You're going to get someone that will try their best to steer you in the right direction, whether it's AIM or towards hospice. But again, we're here to help if and as much as possible. So either visiting the website or just giving us a call. Information is free, and it doesn't hurt to ask.
Okay.
I will direct them, they can ask for me, and I will take the phone calls, and if I happen to be unavailable, I always will get back to them and put them in the right direction. If it's not for us, I will try and give them other information as well, but generally speaking, people who just call and want to know about the program, I will explain it in detail.
Excellent. Well, our time is almost up. Do you have some parting thoughts for our viewers?
I'll tell you a little patient story.
Please.
I had a phone call from a patient recently who was calling because she was not feeling well, thought she probably had a flu, has been to the hospital and the emergency room several times, but has now been on our service for months, and told me that she really was sick, and she described her symptoms, and I said, well, that sounds like you might have to go to the emergency room. And she said, nope, not going. She said, first of all, everybody there is sick. She said, I don't want to go to the emergency room. I don't want to be admitted to the hospital. They're all sick there. Then I'll get sicker. She goes, is there any possibility that you folks can possibly please see me or do something for me? She was well known to us, and so I spoke to the nurse practitioner, and we managed to get her in and get her seen, and she's still home battling her flu symptoms, but she's feeling much better about it. So she was afraid she was going to get sicker, really did not want to go. And that's what it's about. I mean, they have that comfort level to call us up and say, what can I do? Where do I go? What do I do? And don't send me to the hospital.
Wow.
So that's, those are our success stories. We like to hear that our patients are comfortable enough and are now educated enough, and we don't judge them. Their goal is their goal, not ours. We can point them in the directions and they make the choices. And so it's nice to get those phone calls from patients. Even though she wasn't feeling well, she knew to pick up the phone and call. She knew that she'd get the support by calling us.
Oh, that's wonderful. What an endorsement of what you do. And with the understanding that your goal cannot be a cure. Your goal must be just quality of life and the kind of security that comes with knowing you're on the other end of the phone.
Yep. And that's the benefits that come out of that are amazing.
Yeah. Kelly, parting words.
I think, I said this earlier, but I think that's my main message anytime I speak about any of the programs that we offer, whether it's AIM or hospice or our work with caregivers. These illnesses occur no matter what. It's unfortunate. When if your sink, if there's water spewing out of it, you call a plumber, you call an expert, someone that knows what's going on. If you have a chronic illness, if you have a loved one with, that is facing end-of-life issues, we're the experts. Call us and we're here to help. Everyone experiences illness and end of life differently. And it's always nice to have someone that's experienced it previously. You really only get one go around at it. So having someone that can guide you and your family and your loved ones through the entire process is, I think, is a huge asset. So we're here for that, and we're here to help as much as we possibly can.
Thank you.
Thank you.
And thank you for sharing your beautiful facility with us. This is from Hospice and Palliative Care of St. Lawrence Valley. These conversations are production of North Country Matters. This shows a civic collaboration between the St. Lawrence County branch of the American Association of University Women and the League of Women Voters. We are coming to you from Potsdam, New York, the home of Hospice and Palliative Care. And our thanks to you. And next time, remember, our North Country matters.